Our final panel for this afternoon is going to be led by Dr. David Asbow of Chelsea Westminster Hospital, one of our local hosts, and he will do the honors talking about Harmonizing Global Treatment Initiative, Tale of Varied Color Starting Flags.
Do the discussants want to come up? And we can do the introductions. While they're coming up, I just really wanted to thank Sean for that incredibly thought-provoking and sobering talk and film presentation. And I also want to thank IPAC for putting on such a great meeting. It's been a long day, and I really appreciate that you all have stayed. We're going to move straight into the session because I'm sure everyone's keen to probably have a glass of wine and have some dinner. Without further ado, I would like to introduce you to Julio Montaner, who needs no introduction, who will do the presentation, and then after that we'll take a couple of questions for clarification, and I'll introduce the panel. Thank you very much. Julio.
Thank you. I'll be quick. I've been given the task of discussing for you the tale of varied colors starting flags. Namely the heterogeneity of guidelines, or more relevant perhaps, guidelines implementation across the world. I want to start by thanking Soumya Gupta and Ruben Granich, who led most of the work that I'm going to share with you, as well as my colleagues Eleanor Ghosh, Brian Williams, and Badar Assam, who had significant input on the slides that I'm going to show you. I won't dwell on the methods. Suffice to say that Soumya, in particular, did a great job at exploring all of the available databases, publications, experts out there to try to summarize what's the knowledge today in terms of either published or reported guidelines around the world, and that's what I'm going to show you. I'll go through various tables that look like this, and then I'll try to summarize very quickly. You can have these slides if anybody's interested. The last thing I'm going to do is read all those names for you. Those are all the countries for which we had the data. The first table shows the state of antiretroviral therapy initiation for asymptomatic people living with HIV. And the first line there illustrates 9 countries that are currently recommending initiation of treatment irrespective of CD4 count. British Columbia is not a country, but we treat it like a country within Canada. The next one is for those countries that are looking at initiation of antiretroviral therapy using a guideline of 500 CD4s, up to 500 CD4s. For considered above 500 CD4s. The next one, 29 countries, up to 500 CD4s. And the last one that I included in this box is 3 additional countries that recommend for 350 and below, but consider up to 500. And I try to use that breakdown to suggest that these are the sort of the most progressive guidelines out there. The rest of the countries that you see here, some 70 countries or so, are all recommending treatment initiation below 350. If you summarize all of that, and again, I'm not dwelling on the name of the countries or regions, you find that we have 47 countries that represent 36% of the people living with HIV in the world that have what I would consider a fairly permissive guideline approach. But this is guideline. This is not to say that all of those people are on the treatment, of course. And then we have 70 countries with 52% of the burden who don't even get there. So the question is, we're spending a lot of time writing and recommending guidelines. We're not getting the traction that we would like to have. And even in the best case scenario, only 36% of the people living with HIV are exposed, if you want to call it that way, have access to guidelines that we consider progressive at the current time, that would include the current WHO guidelines. This is to show you now the same kind of data but in a graphic fashion so that you see the spread across the world. This is from the Situation Room at UNH, similar to a slide that Ruben showed during his presentation. And if you look there, the blue would be the regions that are recommending treatment irrespective of CD4 counts, and the green would be above 500. If you look at the light green, the blue and the light green combined, there is a bit of a polarization where areas with lower income are clearly lagging behind in terms of the more liberal use of antiretroviral therapy, and this is something that we need to be aware of. Having said that, there is reason to be optimistic, because if you now look at the whole of the African continent and you look at it, how it evolved in this colorimetric system from before 2010 to early 2013 and then late 2013 after the new, more progressive iteration of the WHO guidelines, there seems to be an acceleration in the moving towards more progressive guidelines. But having said that, the gaps are still significant, and it's something to be considered, to be concerned about. The next set of slides try to go deeper into the 2013 WHO guidelines, broken by special criteria, or special subpopulations or subcriteria. So in this case, within the guidelines, we have a group of people that are recommending antiretroviral therapy respective to the CD4 counts. That's only met by nine countries. Let me just move on. So when we look at the published policies for irrespective of CD4 counts, we have a total of 32 countries as listed here. When we looked at for liver disease as a criteria for initiation of treatment, 52 countries have embraced this criteria only. And then when you look at beyond that, the coverage with antiretroviral therapy, you find that there are significant discrepancies in different areas of the world. And even within a region, as you see here in Africa, for example, some areas are above the global coverage, some areas are under the global coverage, suggesting that there is a great deal of heterogeneity. I think this is a good reason why focusing on the guidelines may be the wrong point for emphasis. And perhaps we need to start thinking more in terms of targets of coverage. And when we look at targets of coverage, it'd be useful to look at the targets of coverage based on the single denominator of all people living with HIV. And that was behind, or part of the inspiration to look at a new way of developing targets that would include a single denominator, the people living with HIV. It would be relevant regardless of guidelines. They would be ambitious but potentially achievable. And they would incorporate the cascade of care elements of number of people diagnosed, number of people on antiretroviral therapy, and number of people biologically detectable, so that there would be a quality element also to the new targets. The objective of the targets is no longer satisfying a guideline, but it's actually trying to meet an ultimate impact goal. And in this case, it would be to maximize the effectiveness of the available tools by 2020, with the hope that we would transform the pandemic into an endemic disease by the year 2030. And I thought I'd finish with this slide that I took when Michel Siribe presented the 90-90-90 strategy in Melbourne. It was, to me, a bit of a closing of a circle. Michel in the podium presenting the 90-90-90, and as he was going to start the presentation, he honored Hugh Plange, who was sadly assassinated in the MH17 event. And he presented this slide with a now famous quote that Hugh used to use repeatedly, He used to say, if we can bring a bottle of Coke to every corner of Africa, we should be able to also deliver antiretroviral therapy drugs to every corner of Africa. And interestingly, even before he presented in 1990, the community had a manifestation where they were demanding undetectable viral load as the new standard of care for the world, not knowing, I suspect, that this is exactly what Michel was going to present, which you was instrumental in putting forward, and would have been very happy to see how the community, the science community, and the policy community, in this case represented by Michel, were actually coming together at such a critical time. So thank you very much.
Thank you very much. So I'm joined on my right by Luis Soto Ramirez from Mexico City, and I think you've got experience of writing guidelines. Next to him is Fabio Mesquita, who runs an STI HIV/AIDS program in Brasilia, Brazil, and Andrew Phillips, who's a professor of epidemiology and biostatistics at UCL here in London. We did have a fourth discussant, but I assume that he hasn't made it. So I just wanted to open up by just thinking about what the reality is sort of within countries on the ground in terms of how useful guidelines have been in terms of introducing and expanding ARV rollout, and whether we think that usefulness is perhaps is now being, we need to look at other methods to try and expand access, particularly looking at targets. So maybe we think about Mexico first.
Julio, thanks for this nice review. It's difficult to talk about the differences in the time of where the guidelines were done and were modified. But at least for Mexico, I would like to tell you that Mexico was maybe the first or some of the first countries that set the less than 350 CD4 for antiretroviral treatment initiation in Latin America and the Caribbean, and now it's going to be the last, maybe the last, to set the treatment for all patients, to test and treat. That's not we are not ashamed of that. It's not a race. Sometimes I think that this is something like a race. Who should have that? So let's see who's going to be the first guideline to put more than 1,000 CD4s. No, it's not a race, but we will move. We will move. We are just in the process to change our guidelines. We will move to universal treatment, and that is despite cost. And that is one important thing to comment on guidelines and cost. Because why we need to have guidelines for each country, each region. We can have just one guideline for all the countries, and that is not possible because of the difference in cost and access to drugs. You know, Mexico is the country just behind Cuba, is the country in Latin America and the Caribbean that pays more for antiretroviral drugs. So that's just one of the prices to be close to the U.S. In fact, in Mexico, we used to say, so far from God and so close to the U.S. But that is some consequences of NAFTA and some other commercial trades that obviously will impact in some other commercial issues, bringing drugs that are cheaper. So in that sense, I envy, we Mexicans envy so much the Brazilians that they can produce the drugs at a very low cost. So is that going to cover better treatment? You have to look at the specific issue in each country. For example, in Mexico, more than exactly 73% of the patients that are diagnosed with HIV have less than 200 CD4s. So if you look at the number of the patients that are diagnosed with more than 500 CD4s, it's less than 3%. So this change of the guidelines will impact really just 3% of the patients. So And most of those patients are treated in very specialized clinics where they don't care about guidelines, and they will start treatment even if the guidelines do not say so. So be careful with that. Maybe guidelines are just the way that we put our general tendency of treatment, but are not the real life. In that sense, I can tell you that guidelines in Mexico are not monitoring by any governmental office or any person. So the guidelines are just a really nice text, but there's no way to monitor that, and there's no way to know how many of the cases are treated with the correct treatments, or even with any other treatment that is not the best option. So treatment is prevention. I really like what Ruben said. Treatment is prevention. But before that, treatment is treatment. So we have to treat our patients, and we have to treat all. And that's the way that we will prevent infection. I don't think that we should consider, and there are many opinions that we heard this morning and this afternoon, that we should not consider the best way to start treatment to say you are going to prevent a lot of infections. No, you are going to prevent the deterioration of your body, of your immune system, of everything else. So it's your benefit. And in that sense, we need to be clear about the importance of being undetectable. Because if you are not undetectable, you are not preventing any infection. And if you remember the cascade, the lowest part of the cascade is the undetectability. So we should make better guidelines to maintain people in care and to make them undetectable. That's one last thing that I would like to say. Universal access. We have universal treatment access in Mexico since 2003, and universal access does not mean good treatment. We still have in Mexico, with 11 years of universal access, we still have high mortality rates. So that is not the same thing. So we have to improve our quality of treatment. And in that sense, just one proposal. We should stop thinking and talking about mortality. It's very impressive. Huh? It's very nice to talk. We have 3,600 children that died. We should start talking about life expectancy. We should start talking, and it's going to be more difficult, we should start talking about quality of life. And that's more important than talking about all the mortality.
Thanks. Fabio.
So thank you. Thanks, Julio, for this very interesting overview. We have been discussing this during the whole day, but I think Julio did a good summary of this. I think the good news is that we have a process, and this process looks like an ongoing process in terms of acceleration of access to treatment. I know that there are conflicts, and we could see these conflicts here during the day between the individual care and the public health approach. And those are important because, like, I'm a public health person. I'm a clinician by education. I started to work with HIV in 1987 before ACT, taking care of patients, but my background is public health. And so basically, I think this conflict is important, but what we need to say is that as a government official that in the past have worked in different countries for international organizations, I would say that targets are extremely important and guidelines are extremely important. And I'm talking this in the perspective of public health. And I would say that if we don't have, for instance, the targets for the universal, the Millennium Development Goals for 2015, a lot of countries in the world would never dedicate efforts to control HIV. Some of the countries that I have the opportunity to visit, they decided to take a very serious HIV program because they want to achieve all the Millennium Development Goals to be considered a medium income or a developed country. So the motivation was development. There was nothing to do with humanitarian motivation or healthcare or whatever. So this makes countries to take decisions to move on and to look for the future. And if we consider the historical of these targets, like let's think about the 3x5. We achieved 5 million people taking ARV in 2007, 3 million people. That was not in 2005. But we are going for the 15 by 15, that we're going to achieve 17 million people by 2015, which is over the target. And that was not possible without targets, without goals. So if we think about all the targets in terms of universal access, or even the 90-90-90 for 2020, with the objective to get the end of the epidemic by 2030, and nobody's talking about the end of HIV, nobody's talking about the end of cases of HIV. We are talking about levels, epidemic levels, as we have today. Like we have an epidemic in many countries. We are talking that in 2030, we may got to the point that there is no epidemics. Still, like tuberculosis or other disease, we may have hotspots, places where we got highest epidemics, but those targets are important, as well as guidelines. Because countries need to, the production of global guidelines are based on science, are based on review, are based on deep discussion and debate. And sometimes it's not easy to get a consensus. Like some countries don't want to push from 350 to 500 because they don't have the money to pay for it. Or, and the experts that are in the panel represent this. Some countries want to push for over 500. There are other discussions, but by the end of the day, we try to balance the evidence in science with the possibilities of most of the countries in the world to get there. And when the guidelines came for 350, there are really few countries by the time that got to 350, and that took, Maggie may know better than I, like probably 3, 4, 5 years to get there. Like we probably will need another 2, 3, 5 years to get to 500. And at some point, maybe to over 500, as we are doing in Brazil or other countries are doing, as Julio showed it. So, but guidelines are important because otherwise, each one will organize their own services only according to their own decisions that normally are not based on evidence, are based on finance or local politics or something that you don't have a way to harmonize if each country takes their own decision. So that's why I'm just concluding saying I'm in favor of guidelines and in favor of targets because I think this mobilizes countries to try to get there. And this takes time. It's not in the day after of the launching of the guidelines or the launching of the targets that we can change everything. But I think we are in the right direction.
Thanks. Andrew, I wonder what evidence programs need to deliver cost-effective antiretroviral therapy if we're looking beyond guidelines and just CD4 counts.
You thinking globally?
Yeah, globally, yeah.
So, I mean, I think that it's difficult to disagree with very much at all that's been said today. But the thing I find myself thinking about the the situation, and in particular following up from the WHO guidelines, is that there's mainly very good agreement on some desirable things that country programs need to do in terms of increasing testing, in terms of prioritising treatment at CD4 for those with CD4 350, and then for expanding initiation of treatment, for introducing third line, for introducing viral load monitoring, for prioritising children, etc. What I see as being on the agenda now, what's really important is to get down to real specific policies in terms of prioritising on a day-to-day basis to help individual countries, ministries of health, to be able to make specific decisions at a kind of micro level. And you mentioned, it's mentioned earlier, the cost effectiveness analysis. That's the only framework I know within which we can kind of reasonably do that in a balanced way, so that you can actually make a decision, because we'd like to do all of those things, but basically there's very few countries where they can all be done at once. And at the moment, maybe we could still improve the degree to which we're providing individual guidance to countries in how to prioritise, because it will differ by countries because of different costs, different state of the epidemic, etc., etc. So that's a kind of general comment. Can I make another comment about?
Sure.
So the target of 90-90-90, I agree with making targets. I agree with ambitious targets. What concerns me is not having a target, or in mind a target, to actually at least keep stable levels of condomless sex, because we just must keep our eye on that, because it has the potential to completely undermine the benefits we're getting from antiretroviral treatment. And so I just found myself thinking, let's not forget that most of this is dependent on levels of condomless sex not increasing. And even the 90-90-90, within the context of the MSM, the epidemic in MSM in the UK, would have if we achieve those levels, which would certainly nowhere near close for the first 90. Then it would have a substantial impact, but it's not going to end the epidemic. And so I think that it's a sobering thought. But I agree with setting those targets. There's a couple of other points I could make, but I think I've taken.
So I think that's a really good time to open it up to the audience with that really fairly novel idea. So
can I while somebody is lining up for a question, let me just clarify, because I think you make an excellent point, Andrew. The 90-90-90 is supposed to replace the 15 million by 2015 as the antiretroviral therapy target for the post-2015 Millennium Development Goal, and is over and above the other things that are working, including condom use. So that's contemplated. The focus is on the 15 by 15 coming to an end, and how is it going to be replaced? The 90-90-90 is the proposal.
Okay, thank you. Thanks for the presentation and the discussion. And I just wanted to bring up a few points. Meg Doherty from WHO, because we work very closely on the guidelines, so we sort of know what's going on right now in terms of countries. And I understand the presentation that was made is probably based on data that's been collected over time, and this is real-time data that things are changing on the ground very actively at all times. And I would just say it's probably quite important that you check and verify the data, because currently right now, just looking at the maps, I could see 5 countries in sub-Saharan Africa that have moved and have a printed guideline already to 500. And what we are monitoring ourselves is for our guidelines with the folks who are implementing the guidelines right now in the countries, is they're moving. It doesn't necessarily mean that they're implementing, but they're finding it very difficult to actually find the funding to do what they'd like to do. And so, for example, I think the statement about costing and prioritization, I think it's key. There are investment cases that are created which are based upon national strategic plans for the global fund applications. And what we're seeing is that if that costing is not done very well, or if it changes over time, if they're not using a good point price for their medicines, you end up finding an enormous gap that nobody can fill at this point in time with the flat funding from PEPFAR and the flat, allocated fund from Global Fund. And what's happening is countries to fill that gap are doing things that are off guidelines. And so the question was, do we need guidelines or not? So we need both targets and guidelines. So what we see a country like Zimbabwe being forced to do is purchase medicines that use a nevirapine base, which does not afford you the long-term outcomes that we would hope they would have using an efavirenz-based fixed-dose combination. And then they may or may not be able to expand to 500, although they're doing really well in their program. Same for Zambia, same for Tanzania, same for Mozambique. So I think we have to take a very realistic view of what's going on and really deep dives, not just at where the data are, but how are ministries handling what they can and cannot do with the limited resources that they have. So I think I agree, cost effectiveness, prioritization, very key. But what we don't want to see that is at the effect of going and using off guidelines, meaning evidence-based, based on data, based on clinical trials, best evidence of the best treatment. So to get to 500, if you have to use a poor regimen, if you're using a nevirapine-based regimen for people with a CD4 of 500 or higher, that's a risk. And the risk-benefit balance now has swung in the risky way. So I think we have to be careful. But we encourage expansion. The other thing about targets, I don't think we should pit one against the other. Targets help us get there, and I believe what Fabio said. Guidelines are based on best evidence, input from experts, and if anybody were in a hospital and they said, we're going to go off guidelines for a surgery, or we're going to go off guidelines for inserting a line, or we're going to do things off of our protocol, that hospital will get shut down. So I don't know why we would want to do that for HIV as well. So just to say they both have their place, and I don't think we should have that pitting one against the other discussion any longer. It's sort of an old argument, and we should just move forward and try to support the countries for doing what they need to do and understanding not all of them can go to test and treat in the next year. It's going to take several years, and external advocacy can help, but it's not going to make it happen overnight until the funding is there, and until the fixed-dose combinations at a reasonable price are there, until the ministries feel they can start people and keep them on for life. Because what would be the worst thing? If we start a lot of people on therapy and then we fail to follow through keeping them on therapy. I think I would feel terrible if I couldn't do that for my patients that I take care of. So I think we're all in this together. So the pitting guidelines against another, I think it's old news. Thanks.
Great, thank you. Any comments from the panel while we take the next question? No? Okay. Yeah.
Is that right? Great. I think that, thank you very much for this, and it's an area that I hadn't really considered before. I think there's a chunk of it missing, which is obviously what the people who actually take the pills need to do. I think one of the crucial things about any guidelines and any frameworks for achieving these goals is to look at how they're going to be operationalized, and the success of the operationalization does require very careful integration of or consideration of these issues, but also the quality of services. And I continually see guidelines and frameworks being set up that are kind of in isolation. And I think it's important to join up the dots at all points. And if you're going to create, say, a patient-centered framework for services that wants to achieve these goals, then obviously it's going to then communicate how they are operationalized to make them effective. So can I encourage everybody to think about that aspect at all times too? Does that make sense? Yeah. Okay. Thank you.
Thanks. Other questions? There's one at the back there.
So I just wanted to That's on? Okay. Just wanted to comment on the issue of kind of the price of antiretrovirals, particularly for middle-income countries. So as much as we're talking about, you know, the enablers for treatment and getting people to undetectable and improving quality of medication, we also have to recognize that there are tools that we can't access globally, and those include some of the newer medications that may be better tolerated, and even some of the older tools we can't access necessarily in middle-income countries. So just kind of referencing Mexico, in our last Untangling the Web document, we looked at first-line therapy with tenofovir, emtricitabine, and efavirenz, and we looked at the lowest kind of indicative prices that we could get on the global market, and it was about $128 US per patient per year. Now in Mexico, it was about $2,391 US per patient per year for that same exact combination. And I think, you know, one thing we will have to kind of continue to examine is why is that? Why is there that discrepancy? Now, of course, Mexico is more wealthy than a country like Malawi, but at the same time, the prices are artificially high because of continued patent monopolies. And at one point, do we say, this is a global fight, this is a fight that we all have to take on together, and we have to not only kind of pay attention to the health systems and the way we take care of our patients, but we also have to address the market constrictions that are keeping us from giving the optimal care to our patients. So I guess that was more of a comment than a question, but if anyone has responses, that would be great.
Okay, any other questions or comments? Okay, well, we're moving rapidly towards 7 o'clock, and as I say, it's been a long day, so I'm going to bring the session to a close. I really want to thank the presenter and the discussants for a really interesting discussion, and wish you all a good evening. Thank you very much.